go live in 3, 2, 1.
Welcome everybody to today's Learning Summit, which we will have a focus on sharing the emerging practice on the co-designing of the intermediate care framework or of intermediate care in our integrated care systems. Today is the 4th event of the jointly convened learning network between NHS England and the Care Provider Alliance, and it aims to deepen collaboration between health and social care with a spotlight on local innovation and collaboration. I'm Jenny Keane. I'm the Director of Intermediate Care and Rehabilitation at NHS England, and I will be co-chairing this event today with my colleague Dr. Jane Townsend, who's the current chair of the Care Provider Alliance and also the Chief Executive of the Home Care Association. Today's focus of the Learning Summit is the co-designing of intermediate care services at integrated care systems and the opportunities this presents for NHS, for local authorities and for the social care providers to come together to create a community-based recovery model which enables people to stay well, safe and independent in the place that they call home. My strapline is needing and wanting to be able to enable people to walk, talk, eat, drink and sleep in wherever they call home. We've got a really exciting agenda today, which will open with our reflections as chairs on the national context and with particular reference to the recently published NHS England's Intermediate Care Framework for Rehabilitation, Reablement and Recovery following hospital discharge. We'll then hear about how this has been put into practice, so the actual real bit of the work, with presentations from 2 of our intermediate care discharge frontrunner sites, and that's Warwickshire Care Collaborative and the One Croydon Alliance. The local teams will be sharing practical examples of how they've been trailing new solutions to address discharge challenges and to deliver high quality step down intermediate care alongside local health and social care partners, with the aim of ensuring that their local populations get the care that they need at the right time and in the best place for them. Building on some of those new solutions and models, our final speaker will be Liz Jones, the Policy Director at the National Care Forum, who will spotlight the National Care Forum's recent blueprint on accommodation-based intermediate care. The blueprint complements the NHS England's national framework, and it highlights the key role social care providers have to play in designing this, particularly acknowledging that some people will need to stay in a residential setting temporarily to receive rehabilitation before going home. I think probably one of the key achievements from my perspective this year is actually how well both the frameworks align, both in terms of vision, principles and the outcomes that both are really highlighting as what's required for people. The session then will close with a panel discussion with all of today's speakers. And what I'm going to ask you to do, colleagues on the call, is if you don't mind introducing yourselves into the chat, just so that we know who everybody is that we have on the call. But I'd also really like to welcome you to putting any questions or comments that you have as we go through today's presentations. I'd also like you to give a thumbs up to the questions that really resonate with you, and then we'll pick the key questions at the end to actually to focus on for answers. We do also intend to be able to take the questions that we either haven't been able to or haven't had the time to answer. And as we're sharing the live video, we hope to be able to find a way of getting that resource out to you as well. I'm going to spend just a couple of seconds giving a little bit of an overview of the priorities in the NHS England framework. And for those of you that haven't had the opportunity to review it or to have a look at it yet, it has identified 4 key priority areas. And the 4 key priority areas, number 1 of those is demand and capacity planning. So the need for system oversight and whole system demand and capacity planning across this space. The second priority is workforce utilisation, having the right staff in the right place at the right time, and a real focus that actually to improve capacity it's about our workforce. It's about giving the best opportunities, the best models and tools to our workforce to be able to deliver that. The third of those is implementing effective care transfer hubs. And really important that I emphasise at this point that the care transfer hubs are at system level across health and care. They are not on an acute footprint. And then finally, underpinning all of that, the final priority area is improving data quality and sharing, which is absolutely key. And I don't think there's anybody who would deny that there is a real dearth of good quality data across community health, but even less so in the space of shared integrated data. And there's my alarm telling me that I have reached my endpoint. So all of those four key priority areas that I've referenced, none of those can be realised, even with full resource, full workforce, unless we do the one key thing, which is actually coming together and working well, integrating across health and care, and that will be the key enabler to the implementation of those recommendations. So now it gives me great pleasure, and I'm really pleased to be able to hand over to my co-chair, Dr. Jane Townsend. Jane, look forward to hearing your reflections.
Thank you, Jenny. As Jenny said, I'm Jane Townsend. I'm this year's chair of the Care Provider Alliance and also Chief Exec of the Home Care Association. And on behalf of the Care Provider Alliance, which is the 10 care associations in England representing providers of all types, we're really delighted to be working with our NHS England colleagues to co-design and co-deliver a learning session on intermediate care. People have been talking about intermediate care for years. It's not a new idea. And actually, for a very long time, the goal has been to enable all of us to live well in our communities and keep out of hospital as far as possible. And we can achieve so much when we work together, both the NHS, social care providers, local government, and the voluntary sector as well, to improve outcomes for people in our communities. And there are millions of people across the country that draw on health and care services, and in a range of different settings, some at home, some in care homes, some in extra care, some in hospital sometimes. And we've got over 1.6 million jobs in social care altogether, even larger workforce than the NHS. And really form an essential part of the combined workforce to support our communities. So we're very keen to ensure that we work together in an integrated way and engage at all different levels. We're engaging nationally, but we need to see that engagement at local level as well, particularly to ensure that everyone can access care who needs it in all of its forms. And there are many contributing factors to making this all work, and I think Jenny touched on a key one, which is about relationships and building, working together to solve problems and to identify solutions. And we need to look at sort of different ways of working as well, outside the sort of established structures. And having better IT systems is something that we're all working on, and sharing that data and knowledge. It's important that all of us acknowledge the contribution of informal carers too. So Carers UK have estimated that 10.6 million people are supporting loved ones informally, and they play an absolutely crucial role, and we need to think about how we support them and work with them and support them too. So I'm really excited about the session today, sort of hearing from people who've actually been doing this in practice, not just talking about the theory and writing frameworks, which is very important, isn't it, Jenny? But actually it's what happens on the ground that really matters. And so the first talk is from Warwickshire, and I'm really delighted to welcome Ryan Stocks, who's clinical lead for the Community Recovery Service at South Warwickshire University NHS Foundation Trust, and Sarah Bailey, Operations Manager, Social Care and Support at Warwickshire County Council. So thank you, Ryan and Sarah, over to you.
Thank you very much, much appreciated. So yeah, thank you for having us today. I guess what we wanted to do was give a summary of our frontrunner pilot scheme and I guess share with you some of the actions and the learning that we've done to date. So to start with, why was the change required? I guess like most areas in the country, high demands for support for older people to return home from hospital, increased waiting lists for domiciliary care, and impacts on the acute hospital beds. I guess a quote there from the King's Fund as well. It sounds a bit doom and gloom, but we all know that there is increased demand for our services. The cost of delivering those services is growing, and the pressure and the performance on the NHS is under strain. That being said, next slide, despite the doom and gloom, I think it was really positive to have this announcement from NHS England and the Department of Health regarding the discharge frontrunners. So we were named in Warwickshire as one of the 6 national discharge frontrunners to explore new long-term initiatives to free up hospital beds. We are a 1-year pilot scheme and we've received additional funding from NHS England to support the implementation. And yet locally we've called this service the Community Recovery Service. As I say, what's great from a NHS long-term plan perspective is the profile of out of hospital and intermediate care and that real focus on that. So our service went live on the 24th of April and as a result we've had to have rapid mobilisation, learning very much kind of as we develop our service on the go and continuous learning through that. So the vision of our service, next slide please, is that people in Warwickshire in an acute hospital who require further support to recover will have access to effective therapeutic intermediate care service within 24 hours of no longer meeting criteria to reside. So essentially someone in hospital who no longer needs to be there can be discharged within 24 hours and receive therapeutic input at home. Alongside this, the idea was that very much in line with the intermediate care framework and what was already being discussed around that integration. So integrating the commissioning and the delivery arrangement between Warwickshire County Council and South Warwickshire Foundation Trust, so social and health. Objectives for the service, 3 simple objectives really. The first being, I say simple but large. The first being to reduce hospital length of stay. So those people, as we said, that no longer need to be in hospital and who should be at home, getting them home sooner. The second then being to increase the number of people receiving rehabilitation and recovery after a hospital admission, with the aim to improve people's functional outcomes and their independence and quality of life, and in doing so helping to support achieve our third objective, which is to reduce individuals' long-term care needs. And the hope from doing that is that we reduce the demand and acuity of the impact, resulting in decreased long-term care costs within social care. Next slide, please. So our service then, what is it? As I say, we're an integrated intermediate care service. We provide up to 6 weeks of free care, and I've kind of bolded the up to because that's something that we've learned from around managing expectations. This is dependent on individuals' needs. So 6 weeks is the maximum, but not everybody needs that. And we need to make sure we're tailoring the service to their needs. The aim, as I said before, is for care to commence within 24 hours of the service receiving the referral. All patients now go home with 4 care calls, and the hospital now only need to decide whether they are singles or doubles, rather than keeping patients, assessing patients and prescribing the amount of care calls someone needs. And this is in line with the National Discharge to Assess ethos and discharge policy. Within 2 hours of the individual then being home, a carer assessment is completed to understand someone's individual needs. And all patients have the opportunity to access therapy, and we screen those referrals to determine the need. Throughout the service, we then provide continuous assessment and look to reduce the care as appropriate and to meet those individual needs wherever possible. As I said at the start, someone can exit the pathway at any point. So if they've returned to their previous level of function, they've achieved a new baseline, or they require a new long-term package of care. Next slide, please. So phase one, what have we achieved so far? I guess this doesn't cover everything, but a brief summary. So our pathway one service, so that's patients going home with additional support, is pathway one. We previously had 9 services and we've consolidated that to 3. So we're now left with our service, community recovery service, which is essentially for anyone with a new or increased care need or a recovery rehabilitation need. We've still got our reablement service, and that's I guess a similar service but with a more rigid criteria for patients needing that support, who are more likely to return to independence and have no long-term care needs. And then we've got our community response team, which is more around our admission avoidance. The service has commissioned 7 providers directly, which I'll come back to in a moment. We've established a service criteria and spent a long time developing our standard operating procedure, which I think has been instrumental in making sure that we've now got an established service with working practices, and things are starting to work as business as usual now as we approach the 6-month mark. We've focused on improving that integration and our multidisciplinary team working across health and social care, and I'll discuss a little bit more how we've done that in a moment. And one of those methods that we've used is through our multidisciplinary team meetings. So 3 times a week, once for each locality, so North Warwickshire, South Warwickshire and Rugby. We have a meeting where we discuss all patients on our caseload. We discuss any troubleshooting of problems, what our capacity in the system is, but predominantly making sure that we're getting flow through the system. So are we progressing patients, and if not, are we moving them on to a service such as long-term care that meets their needs after that period of intermediate care? And as I've already touched upon, that continuous refine and review, ongoing learning. So what have we done with our care providers? As I say, we commissioned 7 providers by the Warwickshire County Council, where there was a rigorous procurement process. The providers are on an enhanced rate and have block payments. So this kind of mitigates any issues around capacity and payments and reducing care calls. Instead, they have set hours, and if they reduce the care calls for one client, then those hours go back into their capacity availability to support someone being discharged from home. This allows us to have more targeted use of our capacity within the domiciliary care market. But the key change for the providers is they've been given full autonomy to assess and amend care packages. So this is more autonomy than they've had before, and from their perspective is a welcomed change. But it's a new concept, and so we're making sure that we're supporting them with our therapy input, the multidisciplinary team meetings, and also through a training programme which is being delivered by Warwickshire County Council. Other ways that we've been working on integrating with our care providers is with our therapists. So after a therapist has completed an initial assessment, they'll now share their goals with the care agency. Care agency can then start working on supporting exercises or independence. We've got established methods of communication now, and we held a really productive engagement session between the therapists and the providers where they understood each other's roles, understood each other's needs and the challenges, and also demonstrated that as a service, a lot of the challenges we're facing together as one integrated team. The support for the providers also, it comes from things like our contact list and escalation log scenarios, so that they have something to refer to. They've also got links for support within the council and those multidisciplinary team meetings that we discussed earlier. But I think the key is that anecdotally, we've heard really positive feedback from the care staff and their managers that the care staff are having much greater job satisfaction, and they feel valued as a result of the community recovery service. The next slide, going on to our therapy staff. So what have we done within our therapy workforce? Very much, I guess, what Jenny was mentioning around the intermediate care framework, it very much aligns to that, which is positive. We've been doing a lot of work on our capacity and demand, so understanding how we can maximise our capacity, and that's been also with a linked piece of work on our workforce planning, so making sure that we've got the right staff in post to meet the needs of our client base, and that we're developing our recruitment planning around that workforce plan. A big drive within that has been related to our Band 4 assistant practitioners. Again, that's kind of being pushed from NHS England, that we're bolstering our unregistered workforce, and there's a lot of behaviour change work that's gone alongside that to support our staff in changing the way we work and changing our practices. Again, going back to capacity and demand about the efficiency, it's around finding new ways of working. So we've been doing process mapping and looking at those processes to streamline things such as our admin and coordinator processes, avoiding duplication and bottlenecks. And then finally, what I've already spoken about before with the providers, really focusing on that partnership and integrated working to make sure that we're kind of approaching this as one team, and all have the same goals that we're working towards with patients. A little bit of data so far around what our service is achieving. So we've had well over 1,000 referrals to date, and as of 5 days ago, we had 1,175 patients who started on the community recovery service, which is fantastic. We're not quite achieving that aim of getting people home within 24 hours, but what we can see is that 53% of clients or individuals receive care and are home within 3 days of the referral being received. If we go on to the next slide, though, what we can see is, I guess, from the bottom left graph, the impact that the demand is having on the system. So although this specifically relates to therapy, it's also on the care provision and Warwickshire County Council. So we've had an 80% increase in the number of patients receiving therapy since starting CRS, and you can see that huge jump since April. And as I say, the impact and the challenge that that has on all of our teams working across the system. However, it's really positive because it demonstrates that we're already working and achieving objective number 2, which was to increase the number of people receiving rehab after an acute hospital admission. As I said earlier, we screen all of the referrals and we're seeing about 85% of all of the patients on the pathway, which is great. With regards to our hospital length of stay, as that was one of our objectives, difficult to get the data at the moment, and ongoing developments of that data set, as Jenny highlighted before. Anecdotally, we're hearing from our discharge teams that they feel a reduction in waiting times for packages of care, which is great. And if we have a look at the graphs there, we can see that the average length of stay for admitted patients in Warwickshire overall and for over 65 is being reduced, though this hasn't been categorised just for pathway 1. So this isn't just for those patients going home with our service. So we need to develop that data set. And then we also need to develop the data set for exits and long-term care. Are we having that impact on reducing the long-term care down? We know the majority of our exits do go home with long-term care, and that's kind of to do with the acuity of our caseloads. The ones that, as I say, return independent will generally go down our reablement pathway. But what we need to start looking at is if those individuals historically would have gone home with, I don't know, 3 care calls long term, have we managed to reduce that down to 2 or 1 care calls long term through the input of our rehabilitation service? Just from a patient level feedback perspective, aside from all of the data and the numbers, go on to the next slide. I won't go into it all, but we've started collecting and really pushing to get patient and staff feedback at this point, and it's been really positive to hear some of the great experiences that our service users have achieved, which is fantastic. For instance, people saying that it's an excellent service with positive outcomes, case studies of people going home transfer only or hoist as a backup, who are now mobilising independently, mobilising around the park with family members, and really seeing that impact on individuals' quality of life, with one report saying that the service made a phenomenal difference to her recovery. So that's really great to see. The next slide just gave a couple of provider case studies, and I'll just whiz through these because I'm mindful of time. But what we can see is the range in the impact that we have. So as I say, some patients exit with long-term care still, but we're reducing that long-term care. So they came home with 4 care calls, but actually we reduced that to 2 care calls long-term. They were all care in bed, but now they're walking with a frame. The next example is someone who was discharged independent. So for the first 3 weeks, they were pretty much all care in bed. They had a lot of pain that was limiting, but actually over the 6 weeks we increased the mobility and they had no long-term care requirement afterwards, which is great. On the other hand, we do appreciate that some patients don't get better, and while they come home with 4 care calls and they exit with 4 care calls, we can still have an impact, and the providers reported improving someone's kind of mental health well-being, bringing someone out of their shell, making them more talkative, and having a more positive outlook, which is really fantastic to still see. As I say, I'm mindful of time, so I won't go into phase 2 where we're going too much. As I say, it's all about now still refining and developing the service that we've got, expanding that data set, continuing with our workforce planning and the behaviour change, looking at how we can integrate and collaborate even further more effectively. But just the final thing that I will touch upon is the learning. I think some of the key points is around engagement. While we've communicated and engaged, I think, very well with all our stakeholders, people always want more, and I think there's learning that we can do more, and we continue to develop the areas in which we communicate with our stakeholders. The next would be managing expectations, so being really clear with patients and staff around what the service can achieve. So things like the aim of getting someone home for 24 hours, that's not something we can guarantee or promise, it's what we're working towards. Service user engagement and feedback, as I say, we've started collecting that, but I think on reflection we could have and should have been collecting that earlier, and we need to look at co-design and integrating our feedback from the patients. Again, as Jenny mentioned earlier, technology and the data, I think while we have done come great lengths in integrating, the data and the technology does limit us. So within the council, within the healthcare service and our providers, we all use different services, and we've had to overcome a number of barriers with sharing data, but actually having a true integrated data set is something that's very challenging to achieve. And just a few examples there that I've written in the bottom corner that we're currently working from current learning around hospital readmissions, multiple admissions onto our pathway, our business support processes and our commissioning review. Sorry, I've probably spoken at 100 miles an hour and wanted to rattle through as much as I could in the time given, but I hope that gives a bit of a summary, and look forward to answering some questions in the future in a bit of time. Thank you.
Thank you very much, Ryan. Oh, sorry, Jenny.
Sorry, it's you, Jane.
I guess we'll just move straight on to Sarah, and then we're leaving all questions until the end, the discussion till the end.
Yeah.
Thank you for putting questions in the Q&A. So maybe Ryan, you could start having a look through some of those, because there's some asking specific things about what you've said, and then maybe we can bring you in just to quickly address some of those.
Absolutely.
Sarah.
Yeah, Sarah, as in Sarah Bailey, yeah. Sorry,
Yes.
Ryan,
Sarah Bailey.
Yeah, hello. I'm Sarah Bailey, Social Care and Support, Warwickshire County Council. Ryan's done the presentation on behalf of both of us. He put all the hard work into the presentation, and I supported that for him to do. So I've got nothing more to add, but I'm here to answer any questions about any adult social care related queries that might come through. Is that okay? Because we only have 15 minutes.
Yeah, no, that's fine. Thank you.
Okay.
Jenny, do you want to crack on with the next bit, or have we got 2 minutes to answer any direct questions.
We do have some time. You have generated a lot of questions, which I've said in our chat you usually do, because it's an excellent presentation. So I wonder if we could take a few of those questions.
Happily, yeah, that's fine.
Yeah. So I am going to go into chat here. I don't have access to them all.
Yeah, so there's, maybe we just kick off with, I was very pleased to hear about the autonomy that you're giving to providers, and there's a question in here about trusted assessor training and whether you've done anything in particular to support and enable that shift of responsibility, which is really good. So
yeah, no, definitely. So yeah, the council have quite a well-developed training programme for the care providers within our domiciliary care market, but that was expanded and adapted when the Community Recovery Service came about. So further training was delivered around re-ablement and providing a re-ablement approach and encouraging independence and reducing care needs. Other training was given around from more of a therapy perspective around orthotics and braces and understanding the type of clients that were getting home from hospital. But I think one positive that we've identified is there is a further learning need there, and this is a huge cultural change for providers. I've been out with some of the care agencies recently, and there's still that I guess confidence around reducing care calls and making individuals more independent. So while we have tried to support that as well through joint assessments with therapists, having our MDT meetings, we are currently working on expanding even further training with the carers around how to make those assessments and make that as robust as possible.
and just what a lot of providers find just generally, I'm not talking about Warwickshire specifically, but that communication between the hospital and the community doesn't always work that smoothly. What have you put in place to make that work where you are?
Yeah, so we developed the single discharge referral form, which has basically mandatory information that we need for all discharges. The referrals come through to the council, and that referral, all of that information is passed on to the care staff, so they receive all of the relevant information. Those referrals also go through to the therapists as well, so if we sometimes find that the information doesn't quite have everything that we need, the therapist will be able to call up the hospitals or call up the patients to acquire that additional information, and we would absolutely encourage that sharing of that information with the carers, which, as I say, we do. So after an initial therapy assessment, once the therapists have identified further kind of goals for rehabilitation and recovery, we share those goals and kind of tips and exercises and things that we want the carers to support the patient in achieving.
Brilliant, thank you.
Can
Jenny
I just
Anderson,
add, oh, just going to say, Jane, I think that point about a re-ablement and recovery mindset is from a provider perspective in terms of how we equip our staff, whether it's in an accommodation-based setting or in home care setting. I think that mindset for recovery and re-ablement is really key. And if we've got time later, it'd be quite interesting to explore that a little bit more in terms of how you're equipping for re-ablement long term versus re-ablement short term, and whether that is you're expecting that to kind of change some of the things you're requiring of your home care providers in the longer term, because I can see that mindset has got some legs for, you know, the bigger picture as well as for supporting the time immediately after discharge.
I think you're absolutely right, Liz. I don't think it does, although it applies very much to intermediate care, the principles are transferable and can be applied throughout domiciliary care and at any point in that care provision while someone's at home. But we appreciate the challenge that the carers have, because for them, they're not just delivering care for our service. They are still providing care to the wider domiciliary care market, and there is that approach of, well, is this patient on CRS or is this patient on dom care, and how do I need to adapt my approach to that different cohort of patients? So it's something that we need to continue to develop, and I think we've got a really good buy-in from the care managers and from the care agencies around buying into this kind of vision and this process. It's how we now support that to be fed down to the care staff on the ground to make sure that they are confident in providing that approach and equipped to make that approach.
Brilliant, thank you. Now, in the interest of time, I'll hand back to Jenny, and then we can come back to some of these issues later. Thank you.
Okay, thank you. And to just confuse matters further, we're going to another Jennifer. No, we're going to Laura, sorry, in Croydon for our second system. Hi, Laura.
Hello, we will be talking, Jennifer will also be talking.
Yeah.
So yes, there's a few of us giving this presentation. So I'll start. I'm Laura Jenner, I'm Deputy Director of the One Croydon Alliance. I'm just going to give you a quick overview of where we've got to with frontrunner, and I'll pass you over to our frontline staff who do the doing. Next slide, please. So just really quickly, so we're part of One Croydon Alliance, and it's made up of a number of providers in Croydon, the local authority, our health service, Age UK, SLAM, and our GP collaborative. We've been an alliance since 2017, and we started off working together with a set of principles to support over 65s, preventing hospital admissions and supporting people living independently in the community. Done very well on that front, and have now moved on to supporting all the full population. Next slide, please. So our issues quite similar to what Warwickshire were just saying. So obviously we had lots of silo teams supporting people with reablement and intermediate care, often complicated processes for getting people into services. And what we found when we did a big deep dive into our demand and capacity was we found that actually our teams across community in particular were seeing the same patients. So we found that about 30% were actually being seen across our therapy services, and even more than that across our district nursing. So we knew that actually we had to try and do things differently to use the resource that we've got in the best way. So really streamlining, looking at what our workforce could do, and training people to support people more holistically. We also knew that we were over prescribing for care, so we've had discharge to assess set up for some time, and what we were finding was that actually it was causing quite a lot of pressure on adult social care, so lots of people getting 6 weeks reablement when actually they could be supported in a bit of a different way. And also our data, I think as Jenny, we talked about this earlier, really hard to get one version of the truth. So we have used frontrunner to really invest in our data sets, and we're now about to go live on having a system that actually connects our hospital IT system with our adult social care. So we're quite excited about that. Next slide, please. So I'll just give you a quick overview of our full frontrunner programme, and then I'll pass you over to the guys that are going to talk to you about one area of it in more detail. So you can see here number 2, the transfer of care hub. So we've got a big piece of work going on within the hospital into community, where we are developing an integrated team that will have a joint health and social care manager, new blended roles. And we've spent a lot of time looking at the tasks across the social workers that are in the hospital and the discharge coordinators, and are bringing together this new role. So we're hoping to go live with that soon. And then if you see 3A, which is what the guys are going to talk to you about in a bit more detail, we have been developing a new wraparound service. This is a holistic approach with health and social care, and this is for up to 7 days. And we were introducing this because what we found from before was that we were overprescribing, lots of people going on, and we were not using our resource in the best way. 3B, we are continuing our integration. So we've pulled together all the therapy services now. So we have got one reablement and rehab service, and that's made up of our reablement team and the therapy services. So our falls, DOMI physio, and therapy services. So that's brilliant, and they've streamlined all of their assessments and processes. So that should hopefully reduce our waiting times that we were finding that we were creating. The other bits, just to add on, we talked a little bit about care homes. So we've got a couple of big council care homes. We're looking at the moment how we can develop them into centres of excellences. So having more rehab reablement beds, but also having our recovery team based there, so that it can be a place that people come to, but also a place if people do need a bedded facility for some time. And just underneath, you'll see in the grey boxes there, we are developing a joint budget. So we'll have two big joint budgets, one for the transfer of care hub. So our joint manager will have access to that, and this will be jointly funded. And then for our wraparound and recovery, we'll have a separate contract again, which will be joint. So those teams will be able to recruit and work together. And the IT system that we're bringing in is called Patienteer, and we're buying APIs for any of those technical people out there that know what I'm talking about, so that we can connect our IT systems. So I'm going to pass you over now to Jennifer, who is going to give you a bit more detail about what we've been doing in our new wraparound service. Thanks.
Good afternoon, everyone. I'm just going to pick a few points from the principles of our wraparound service, but first I'd like to just give you a brief insight into what wraparound is. So our wraparound service is for 7 days, and the purpose of this wraparound is that patients who are being discharged into the community, they can come out of hospital knowing that they're going to have full support around them, and that holistic approach on the first 7 days of discharge. And the part of that wraparound is we have a daily MDT. That MDT consists of our community pharmacist, therapist, our nurse. We also have our reablement officers and our care agency. So what we are doing in wraparound is actually working hand in hand with that care agency and ensuring, as Jenny said earlier, we're having the right people in the right place with the right tools to actually ensure that that patient is getting the optimum service that we can provide to get them back on their feet to their baseline prior to hospital admission, and them knowing who they can speak to and who they know they're in contact with someone on a daily basis. Our MDT meeting, we discuss each patient, which is in our wraparound service. So we know from our working hand in hand with our care agency exactly what's happening with that patient, if any concerns are raised. And as I said earlier, we have the right people in to answer those questions and to give guidance, give staff the confidence to know how to move forward if a situation arises. And we have had on our wraparound as well our community geriatrician who supports us when we come up with more complex patients. So this has really given us good insight into joint learning, the way we collaborate, the way we work in partnership as a system. So what we have been able to do with our holistic support from health and social care for that safe discharge is we've really built close relationships with our hospital team to ensure that we're getting the information required on that discharge for that patient to enable them to properly support them. We have also been able to, could you go back to the next slide, please? Sorry. Yes, that's it. Yeah. So we've also been able to ensure that we have, as I said, relevant information. So we've created a whole system approach with our wider social care team, as well as our third sector partners. When I say third sector partners, it's our care agencies, not just our care agencies, but our voluntary sector, as well as, for example, Age UK and other systems. So we aim to ensure that within our 7-day wraparound, we actually see our patients within 24 hours of discharge, but our care agency go in first within a few hours of that person actually arriving at home. So we have used this opportunity of wraparound to actually be able to work alongside our care agency to set KPIs, to set standards, to actually create this patient-centered approach for each individual that come through our service. And with this, our motto is to ensure that the agency is actually doing with the resident and not for the resident, because we need our resident to get back to keep getting used to being at home again and doing things and supporting themselves. Also, with our joint learning and our collaboration, what's going forward is really ensure that our residents are receiving a high quality of care. And can you go on to the next slide, please? I'm just going to give you some insight into what our service looked like before. So our service prior to this wraparound service, all our discharge to assess referrals came through the system. The Part B was completed, or the assessment at home was completed within 24 hours by the health and wellbeing assessor. The package of care was in place. And then between day 1 and 6 weeks, we then completed our Part C. So the patient could have been they could exit the service at any point as they develop. And then our ongoing care was provided by our ICN Plus, and our ICN Plus integrated community network is our neighbourhood teams actually picking them up with support again from our voluntary service, our mental health service, and many other services we have in our community to support individuals. Our wraparound model now, the discharge to assess referral is received. We actually have a triage team as well. They make sure all the information is there for that resident on discharge on that referral, so that we could get that care package put in place, ensuring it's put in place with what that patient actually needs. We then do our welfare check or our visit with the care agency within 24 hours. Our health and wellbeing assessor will go out with the care agency to sit down with that resident, have a good conversation and set goals. We then have, as I said earlier, our MDT, where we work with our delivery partner, which is our agency, our nurse, our therapist, our pharmacist, to ensure, and our pharmacist, as well as the individual who actually assess that patient, to actually work out and look at that holistic assessment to make sure that that assessment has been completed to a high standard, and to ensure that we're not missing anything regarding what that patient's needs may be. And this is provided, and our recovery of care is provided by our reablement and rehab provision, which is part of what we currently have called as the LIFE team, who manages all hospital discharges in the community. So the objective of our wraparound was to increase our residents' independence and reduce over provision of intermediate ongoing care, and to reduce readmissions. Next slide, please. This is just an overview of our wraparound. Our wraparound prototype, we actually used our internal reablement service as well as an external care agency to provide that support. And what we've identified and the learning that we've received from we've gathered from our prototype is basically that we need to have a hybrid model of working collaboratively, so that we can actually still continue to use our internal reablement service, but also working alongside our external care agency as well. Due to the demographics of Croydon is quite a large borough. We've identified that we have to ensure that we set our standards and we work with our care agencies hand in hand in providing a service that is So there's no inequalities for any resident, no matter where you live in the borough. So everyone receives the same standard of care moving forward. So this for us has been quite positive. We've got positive feedback from the system as a whole, and we've had some amazing outcomes from our residents, amazing outcomes from identifying that residents within the 7-day wraparound. What we've identified is a lot of the patients, quite a few of our patients who's been through the wraparound after 7 days no longer need further service, because we've started that reablement process from day one, and we'll be able to identify to ensure they go along the right pathway, for example, therapy input, as well as ongoing support in the community moving forward and for the long term of that patient's best health and the best outcomes for them long term. So I'm now going to pass you on to Corolla, but before I do, just one more thing. Working alongside our care agency as our partner, we really worked with them hand in hand, making them feel part of the team. So they were not sitting outside. We worked alongside them. We gave them easy access to equipment. So when equipment was identified, they could actually make a call, collect that equipment and provide it to that resident on the same day. So we wanted to make them feel as if they're not sitting outside, we're just working together hand in hand. And I must say it's been an amazing experience. And I'm going to pass you on to Corolla, and she's going to give you discuss with you some of the outcomes that we've seen from our model, wraparound model. Thank you.
Yes, good afternoon all. My name is Carola Costagliola and I manage the community reablement and the A&E liaison on behalf of Croydon. I'm just gonna go through quickly one of the patients that was lucky enough to go through our wraparound service. I'm gonna try to be as quick as possible. So this gentleman initially spent 10 days in hospital due to acute pancreatitis. He was then discharged onto our wraparound service. Also, what we found out is that there was a background of different health situation as well, together with an esophageal cancer, which unfortunately was not mentioned on the original D2A. This patient was discharged on the 17th. In agreement with the hospital, he went home under the care of the wife, who the first day did not want a visit from the service. She then called us to say that she needed help, so we were lucky enough to send A&E liaison carers for a visit. We identified there and then the need of pads, which we had back in the office, so somebody else went out and delivered these pads. Unfortunately, this gentleman was experiencing quite a lot of bowel movements due to his pancreatitis. The wife was happy and less stressed because she had the pads at hand. The day after the reablement, seniors went out to carry out the proper assessment. We identified and then delivered on the same day equipment. That's why touching on what Jennifer was saying is very important for the success of our services to be able to identify and deliver equipment kind of straight away. Because we have noticed that by doing so, we are able to move patient on more successfully and safely. The day after we went back in as per contract, we realized that unfortunately this gentleman has deteriorated. Because we work in a multidisciplinary team, we were able to speak to rapid response, who went out straight away, assessed the need of this gentleman to go back to hospital for proper care. He was then again discharged 10 days later with new medication. My seniors went back in and we identified the need to involve ICN, another professional colleagues that we have in our team. Then we started the journey there and then. So on the 23, this gentleman started the journey on a wraparound. Due to the fact that he already had equipment in place, we were able to reable him within 6 days. He was independent with his personal care. We then decided, because his main goals was to be independent with his mobility indoor and outdoor, we kept 1 call per day for exercises. Within 5 days, this gentleman was independent and more sure on his feet with his mobility outdoor. We reduced then our visits to 3 days. Then we discharged 5 days later. This gentleman was independent and there was no need for ongoing package of care. More or less, he stayed in the service, give and take 14 days in total. The key lesson that we have identified in the service is, again, equipment, is the importance of being able to refer forward to colleagues within the service and also to work in partnership. What we also put lots of pressure on is the mental health side of what we do. We don't have to forget that, yes, we're trying to look after the body, but we need to look after the mind as well, especially for those patients who have a main carer in the house. So, i.e., for example, the wife or the husband. This is very important for the success of what we do. All in all, it's been a great success, and these gentlemen, like many others, were finished and discharged from the service with no ongoing package of care. Thank you.
Thank you very much indeed, Carola. In the interest of time, we'll save the questions to the end. And I want to hand over now to my colleague, Liz Jones. We've heard this afternoon now already quite a lot about home-based support and care in intermediate care, but there's also a place for facilities-based services, such as in care homes. And Liz is going to be talking about a blueprint that the National Care Forum have put together to look at how that could work as well as possible. Over to you, Liz.
Thank you very much. So I'm Liz, I'm the Policy Director at the National Care Forum. We represent not-for-profit providers of care and support. And we were involved earlier on with the development of the intermediate care programme. If you want to move the slide on, that will be great. Thank you. So we were hearing a lot about the focus on involving providers of home care in the intermediate care approach, and providing some of the things we've heard from both Warwickshire and Croydon, and actually Leeds as well. We heard from them in a separate webinar. So that point about wraparound care prior to the point that you leave hospital is absolutely critical in terms of both our kind of long-term ambitions for our older people and the baseline level of independence we want to get them back to, but also the kind of immediate opportunities for recovery and reablement. One of the things we were, however, hearing, which concerned us a bit, was a sense that there is regular overprescription of care, and that care providers who run older people's care settings were either potentially complicit in that, or at least inadvertently not properly enabling a short-term focused recovery and reablement stay. And because we had lots of members who have been providing intermediate care, step-down care, whatever you'd like to call it, for a number of years, we thought it would be very helpful to kind of identify what they felt were the key ingredients to a really successful accommodation-based, whether it's care home or community hospital, whatever the setting, a really effective accommodation-based intermediate care service. We thought it'd be useful for providers contemplating either upping their game or developing new services. And we thought it would be really helpful for commissioners to understand what those key ingredients might look like. And actually listening to our colleagues from Croydon and Warwickshire now, just on this session, it strikes me that quite a lot of our key ingredients, probably apart from environment, are really relevant for our home care colleagues as well. So there were 5 key ingredients that were developed with our colleagues across the sector, and we had input beyond National Care Forum members, actually. The 5 key ingredients for a really successful accommodation-based intermediate care service are shown on the slide, and I'll just talk a little bit to them, but I will also pop in the chat where you can look at the blueprint in more detail. So environment really matters. You know, lots of residential nursing and dementia care homes are where people live. That's their home, that's where they live long term. Actually, for recovery and reablement, you need a different sort of environment. It needs to be geared towards rehabilitation, recovery. It needs to have as much opportunity for that physio and OT input, for those exercises, for mobility, for building confidence in your environment before you go home. So a well-designed rehab and recovery and reablement environment will make all the difference. Some of our members were offering things like their own physios and OTs that they employed. They had designated therapy areas, gyms. They were looking at the way that the kitchen and the living space was laid out, access to the garden, ability to move around, support to use equipment properly. So really trying to think about every step being along that recovery and reablement journey. Workforce is key, and that was why I was interested earlier in how Warwickshire and Croydon are thinking about this. The mindset for a short-term recovery and reablement service is quite different to the mindset for delivering really great quality long-term care. Having an intermediate care lead, that person who is the coordinator and who is part of the movers and shakers in the multidisciplinary setup is really important. That person who is taking responsibility for people before they arrive to plan their whole journey in that setting and then the way home. That lead role is really key, but the support workers, the care staff, any of the therapists who are working in that setting also need to have that reablement mindset. So every interaction is potentially a rehabilitative and recovery interaction, really about building confidence and building skills. We've heard a lot about the transfer of care hub skills from Croydon, and actually those skills are needed in any intermediate care setting in terms of having the right people round the table to make things happen, give you access to the right follow-up services, access to the right assessments, access to the right therapists and experts, and also thinking properly about what is needed in advance of that person going home. So hearing about the wraparound service, I've got lots of questions about the housing aspect, and you know, you need to have things in place before people arrive, actually, if you've understood exactly what their needs are going to be. Even if those needs are only 2 to 3 weeks, people arriving home without those things will not have as much confidence and not progress as quickly as if they had them. We've talked a lot about technology, and I was very excited by Croydon's gains in terms of connecting their IT system to across hospitals to adult social care, and the API joy that somebody mentioned. Our members where they've managed to run really successful services have got that joined up tech and data. So information about that person's needs is going straight into their digital social care record before they arrive in the setting. The care planning has been started with that person, with their family, with the experts, the medical experts, the clinicians, the geriatrician if we've got one. You know, that information is already with the provider of the service, so they can A, make sure they can meet that person's needs properly, and B, they can start planning for that full recovery reablement. So digital systems, communication and data sharing is absolutely critical. And I think Jane's mentioned before that we're doing a lot across the adult social care sector to really try and move us along that digital dial. And so doing it in partnership for the purposes of effective discharge and recovery is really key. And then no one's really mentioned money, so I'm going to mention money. The fifth ingredient, and it doesn't really matter whether you're providing accommodation-based services or home care, is about sustainable commissioning and funding. Of course, if you're running an accommodation-based service, the investment you have to make to deliver a really great quality intermediate care service is very significant. But if you're running a home care service, actually, you need to make equal amounts of investment in your training, in the way that you're designing your services, in making sure your staff can support people appropriately at the right time and can play their part fully in that MDT approach. So there are some case studies with our blueprint. One of our members, WCS Care in Warwickshire, had been working on great intermediate care since 2017. And our members Belong Villages have also been doing this for a number of years. And there's also a great case study that Jane gave us when she ran Somerset Care in a previous life. So some work they did back in 2015. So we've been at this for a long time. And I would say that there's a couple of things that I just want to draw out, really. We've heard about the importance of partnership and working with your care provider sector to make this a reality. And quite often care providers are seen as people that you buy stuff off, whether that's hours or beds, and not really seen as kind of strategic partners or indeed strategic leaders. You know, some of the organisations we're talking about are very significant businesses running, you know, employing thousands of people, supporting thousands of people. They are big organisations led by people who can offer great strategic leadership. I'd obviously fly the flag for the not-for-profit sector because that's my members, but actually, you know, this is true across the board. So my plea would be that you see your provider sector as strategic partners, people who come with wisdom, innovation, creativity, who are all invested in achieving the best outcomes we can for the people we support, and who really believe in setting that ambition that we've heard about today, that we get people back home at the level of independence as close to the one that they left it. And it is possible, and we can do it. We've heard about some great examples on the call today. And I guess my call to action is, in that capacity and demand planning that Jenny mentioned at the beginning, you will never know how well you can understand your capacity and your demand if you don't involve your providers in that strategic planning now. And extraordinarily, we've had a number of members who've actually had their intermediate care services decommissioned to be stopping in the middle of November. Now, it might be because they're accommodation based and they're not home care focused, but either way, it seems extraordinary. So please do talk to your provider sector, because they will be able to tell you how well and how quickly they can respond to increased demand. And for those of them that have been operating in the patch for a long time, they'll have pretty good insights into what that potential demand might look like. So I'll pop the link in the chat and you can have a look, but thank you for the opportunity to talk about it. And hopefully you'll find, if not all of the ingredients useful, at least some of them. Thank you.
It's you, Jenny.
Thank you very much. Another absolutely, yeah, fabulous insights. And I feel like I need to say, Liz, that from a national perspective, we are, and certainly I am, agnostic of setting. The importance for me is that rehabilitation, rehabilitation recovery takes place. And I don't think we should be having a conversation about whether, you know, beds or home it isn't one or the other. It is what is best for the local population and for the people that they serve. So I'm just looking very quickly at my timetable, and we are going straight. Sorry, it's jumped about on me here. So we do have time now for some questions and answers until 2:50, which is great. So we've got about 10 minutes. So I think before we even get to questions and answers, I think there are some really common themes in the questions and really common themes in the messages that we have put out there. So I'm looking at what are the key questions that have been asked here. So I suppose when I look through them all, there are things that jump out. So one of the ones that I think we haven't quite answered, so I'm going to open it up to, I suppose, to anybody, but how do we get over managing expectations from family, particularly when the care staff are changing to do things to doing with rather than doing for, which is an absolutely key cultural, professional, clinical change. And that question is also referenced the issue with managing risk. So can I ask somebody from either Croydon or Warwickshire to give us an indication of how you've managed that?
I think Carola, you probably be good sort of on the yeah, hands-on support.
What we do, we put lots of emphasis and responsibility onto our seniors, reablement officer, who goes out once the patient is discharged. What we do, we really witness our patients there and then their capability, in the sense that we try to see them mobilizing. What we ask them, for example, to go to the kitchen, to go to the toilet in the state. By doing so, we assess the mobility. We also assess the need maybe to refer on to other services, i.e. for us, our therapy teams. And we also witness what equipment is to be put in place. The goals, they are set on our part A's from hospital. We take them into consideration, but also sometimes we have found out that the goals set on the original document, some of them are not achievable once they're home because of the home environment. So homes, as we all know, they are a little bit different. The stairs might be too steep. There might be too many carpets in the way. So lots of difficulties to get around these things. So our assessors will, sometimes we have to be cruel to be kind. We will reduce care calls originally set up. And we make sure that the family are aware that depending on the cooperation of the patient and dependent on the potential and the goals, whether they're achievable or not, we put down our own assessments, which is the one that we work towards. Obviously, we all know the families are usually more difficult to get on with rather than the patients. So what I said before when I'm presenting my case, we need to put lots of emphasis also in the mental health side of what we do. So take all into consideration main carers, family, friends, neighbors, whoever is involved in the care. But we need to make sure that at the end of the day, we don't promise things that are not achievable, either financially or physically.
Thank you very much. And I'm just going to see, Ryan, do you have anything in particular you could add to that?
Yeah, I think for us, it's been continuously reinforcing, I guess, what the service is in order to meet patient expectations of the service. So we've done a lot of engagement with staff in the acute hospital to make sure that they understand our service, as well as engagement with our therapy staff and the assessors. So at the point they're referred, they're explained the service. When they go home and they see the carers, it's reinforced. When they see the therapist, it's reinforced again. And we've also devised a service leaflet so that they've got that information, because we understand that sometimes they're explained the service when they're in hospital, but actually they're maybe not so well. There's lots going on. They don't always take that information in. So having that kind of information to hand on paper still has been of benefit. But no matter what we do, to an extent, we still get challenges with managing expectations, whether it's the up to 6 weeks or how many care calls you get. There are inevitably going to be challenges with that still, which seem avoidable to an extent.
Thank you very much. I'm going to go to a question on workforce because I think it's come up across a number of the comments, and everybody's referenced it at some point. So there's been a couple of questions. One is around workforce planning, and that's something nationally we've just started a project on trying to actually do some workforce planning across the sector. It's a very, very difficult and an untouched area, but I'm going to ask the front runners around that. But it's not just the workforce planning. I'm hearing a couple of themes. I'm hearing workforce planning. I'm hearing recruitment and retention, particularly around the therapy workforce. I'm hearing about the need to maybe position the therapy workforce at different parts of the pathway. What I haven't seen, but something I'm particularly interested in, is whether we've got the right ratio of registered to unregistered workforce across the patch. And I'm trying to see, am I missing anything else? But yeah, I think it's just, retention, recruitment, demand and capacity planning for workforce, and then do we have the workforce in the right place? So we go and revert.
Sorry, I was going to say, Jenny, there was a question about therapists, because often they're in short supply, and
Yes.
whether any of them have been moved out of acute settings to enable this to happen. So how's all that working?
Okay, I will take that over to I'll answer that last bit first, Jane, before I hand over, which is that is one of the key recommendations in the intermediate care framework, is about actually making sure that we reduce the number of handovers and the amount of assessments happening across the pathway, and that we try to deliver as much of the actual therapy and rehabilitation out of the acute setting as we can. And I think I've provided the link to that model of care with the recommendations of how to do that, and our email address, if that's helpful. So will I go to Ryan first and then flip back to Croydon this time? Ryan, in terms of workforce.
I guess just on your last point, actually, so in Warwickshire, we haven't moved staff from the acute to the community. And while there's, I guess, different perspectives on that, I think one area is that there are always going to be patients in the acute hospital who still need acute therapy input, and so it may just be a change in the way that our acute therapists work. What we've done, from what Jenny was saying regarding the handover, is we don't ask for a prescriptive assessment or goals from the acute staff, so whereby they would maybe potentially keep a patient to understand what their needs are, understand how many care calls they need. All patients now go home with those four care calls, and we complete their kind of goals at home to reduce the amount of assessments and handover and repeat assessments that's completed. As a therapist, though, by background, thinking about capacity and demand and workforce planning, it's not really something we're taught. And I think even as I've moved into management, I think it's an area within healthcare that is has previously been underrepresented. So it's been a steep learning curve for us. We've worked very closely with our data analyst team in the trust to, first of all, make sure, have we got the kind of data architecture actually in place to have that reliable data set to understand how are our staff working, and then compare, well, what is the incoming data demonstrate around what is our new patient demand. We're very fortunate, as Jenny mentioned, about the national piece of work around workforce planning, that as a front runner, we're now working with NHS England on our workforce planning to expand how we kind of formalise that. And the question around the ratio between registered and unregistered staff, that's always a difficult one. There isn't any nationalised standards on how many therapists to patient ratios you should have and what that workforce look like. And I guess that's because it very much depends on your caseload and individual patients. So it's possibly very difficult to prescribe that. But I think the work that we're doing now is to try and look at how can we categorise the acuity of the patients that we're seeing to then determine, well, what level of need and what level of workforce do we actually require within the service. So it's a bit of a woolly answer because it's an ongoing piece of work that we're doing and something that we're very much learning at the moment.
Sorry, Jenny, one thing I was going to say was I was really pleased to hear the Croydon team talking about mental well-being. Quite often I think that it's quite easy to overlook that, and just the experience of being in hospital, can really dent people's confidence, and then you've got a lot of pressure on unpaid family carers too, and their well-being. And maybe we could explore that a bit more, about whether we're doing enough to assess needs of the entire unit and not just the individual.
Yeah, just to come in from the Croydon point of view. So we've actually done a huge amount of work on the demand and capacity, because we were trying to get it right, what we think that we need in the wraparound and then our recovery care. And we are looking at a large pool of unqualified workforce that will be managed by the OTs and the therapists. And you know what we've seen already through the services that we've got, as long as you have got a very robust training program and you've got the managers with the right ethos, you know, it will work. I think it's about having the right access. So that's what we've been seeing within the MDT is you know, for those unqualified staff, them being able to access the qualified staff when they need to, and having that support. It's not easy, is it? But I think it's something that we have to do, because we don't have the therapists at hand. We are also working with our district nurses. That's the next bit we're doing. We've found that they've actually, in some areas, been de-skilled with the way that they're having to sort of do task and pass, and so we are working with them to allow them to have more time to do that more holistic support, so that they can, you know, offer some of the therapeutic services as well.
I think that having had quite a lot of conversations with the district nurses supporting my parents, I would totally endorse that idea of giving them back that kind of skills and holistic overview, and that particularly that preventative angle. I was just answering a question in the chat about really recognising the importance of family unpaid carers, whatever that network is around people. And one of the elements that we've got in the blueprint is really making sure that we are listening to and hearing what family and friends are saying as part of that process to get people back home and to sustain them at home. People's households, people's networks vary a lot, but if we don't listen to those anxieties and we don't address them and we don't get the support at the time that people need it, it is pretty inevitable that that household arrangement or that network arrangement will not work. And I know that people have got all sorts of assumptions on each side, you know, what families want, what it's often the children, isn't it, that are doing this, or the spouse. Versus what the system can offer, and people hearing different things and interpreting them, and getting that a really clear, agreed understanding of what will happen when people are going home, and particularly what will happen if situations deteriorate and people need help immediately because they're in a crisis, a bit like the story we heard about Harold. You know, actually, if we can possibly avoid those crises, we should. But if for some reason we can't, then we need to equip our unpaid carers to feel confident that the system is not abandoning them because their person has released to space in hospital. And that's often the anxiety of family carers, that, you know, the spotlight has moved. And so as soon as they're out of the system will leave them. So it's a really key aspect, and from what I'm hearing from Croydon and Warwickshire is, you know, you're understanding that, and it's getting it systematically involved, as opposed it's about being empowered and being a co-designer of that care, as opposed to being a kind of passive recipient of the care and support.
Jane, do you have a question?
I don't think we've sort of covered quite a few of the questions. I mean, there's quite a few about how colleagues actually go about physically doing the workforce planning and capacity planning. And I'm imagining that this would require a fair amount of data, which perhaps different systems have got to different degrees. So it might be worth hearing a little bit more about that, if that's possible.
Yeah, so I mean, we, as I say, to start with, had to make sure that we had the right data set. So we worked with the data analyst team to understand, well, how do our therapists, for instance, input onto the system their activity, and make sure that the way they input their activity is standardized across the team, so that individuals' kind of activity is monitored. It then took, after quite a few weeks, maybe even a few months of being in the pathway, to understand, well, how many referrals are we getting through, to understand what is therefore our demand. So how many new patients are we seeing? We then cross-referenced how long was a new patient assessment taking, or allocated for a new patient assessment, versus the number that we were getting, to see what amount of time that was taking up of our kind of total workforce capacity. And then had to break down, I guess, staff diaries a little bit further to understand all the different elements of activity, to understand how much time they were spending on admin and how much time they were spending in meetings and things like that. But what it did take was a huge amount of work with our data team to ensure that we standardised the way they were inputting their activity, because we have 3 teams across the county based on locality, and we quickly realised they were all working in slightly different ways. So I think making sure you have that reliable data set as a starting block was really imperative to start with.
Thank you, Jane. I'll maybe add that we have started to do some work with Skills for Health and the Department of Health support, and with Health Education England, to see how we can do this workforce planning across the health and social care workforce, so that we do it in an integrated way.
And just on that, I think we're, as Warwickshire, are working now with Skills for Health around our workforce planning, and what it kind of established was that actually, although we have worked very hard and done a huge amount of work on capacity and demand already, to take that formalised approach and structured approach to workforce planning actually requires something greater than what we've already got. So to have that kind of learning from Skills for Health, and hopefully to be able to then learn from that and implement something, as you say, Jenny, more nationally around how do services within integrated care or across the sectors structure their workforce planning, I think is really key.
Thank you. I'm mindful that we've only got a couple of minutes left, so maybe I'll attempt to share some of the things that have sort of struck me in this before handing back to Jenny. One of the messages I feel that's come up very strongly is the importance of collaboration and genuine partnership working, and that requires, some of the enablers for that are, really good communication. We didn't really talk very much about it, but I think the joint training, in my personal experience and in my previous life, that was so valuable, because that's also a way of building relationships and making sure that some of the nuts and bolts that go on behind the scenes. Liz mentioned about the money, and I think Warwickshire talked about pooled budget and block contracts. That sounds boring, but some of those things really oil the wheels behind the scenes, so you don't spend all your time arguing about this penny here and that penny there. I think the some other practical things around just getting equipment to the right place at the right time, and those sort of things, workforce planning and workforce building, and involving the social care providers as equal partners in those multidisciplinary teams, ensuring that there are tools available for sharing of information. One thing that we perhaps haven't touched on, and I think it would be really good if we could give more consideration, is how we're measuring outcomes. In the study that the work that we did in my previous role, we were collecting data all the way through about how many people were achieving their outcomes, how many people went on to different forms of care, how much it all costs, and having that sort of evidence is really important. And just involving everybody, family carers, the individual obviously at the centre of everything, and keeping all of the different professionals involved is a lot of work, but it does pay dividends, and it means that everyone can operate in a much more flexible way. Jenny, was there anything that you wanted to pull out?
No, I just think from my perspective, I would just like to thank and really acknowledge the excellent presentations that we've got and the willingness to share the learning and their journeys. I think that's really, really powerful. The other reflection I have, Jane, is the real strong sense of doing the right thing for the person and for populations came through really, really strongly. And I think that's why we're here, but we often miss that in trying to get the process and the numbers and everything to line up. But that came through really, really loud and strong. The other thing I'm going to say is you've been fabulous participants. Yes, our speakers have been great and they've really provided us with excellent content, but wow, it is fabulous to have such interested, really keen participants. Jane, I don't know about you, but chairing one of these forums where there isn't participation is actually quite tough going. It's really hard to keep up with the chat, to actually get all of the comments and the collaboration. And that tells me one thing, that tells me we need to have more of these conversations. There's a real appetite for it. And for me, that's the really positive, that's the indicator. People have had questions and we've been able to at least try and answer them.
And if we've missed any, what we'll do is mop them all up and try and answer them when we send round the recording and the summary.
So, thank you, everybody. It's been a pleasure. Thank you.
Thank you. Bye.
Thank you, everybody. Great session.
Thank you.
Thank you.
Thanks a lot.
Bye.